Good afternoon, friends. I am Dr. Saravanan. Today, I am welcoming you all for this topic on epilepsy awareness and its management. Regarding why we chose this topic, yesterday was World International Epilepsy Awareness Day. This is International Epilepsy Awareness Day is observed on the second Monday of every February every year. So this way, the International League Against Epilepsy has earmarked a day and month so that epilepsy awareness is spread. This brings about to educate people about facts about epilepsy and to manage epilepsy in a better way. I, Dr. Saravanan, am practicing as a consultant neurologist at Sagar Hospitals. I have Dr. ViralKumar, who is my very good friend and colleague, practicing consultant neurosurgeon at Sagar Hospital. So we both will be discussing about this topic. I request Dr. Viral to kindly give a brief introduction about himself and to carry forward the discussions.
Good afternoon and thank you very much, Dr. Saravanan. Today we will be discussing the epilepsy program. I, Dr. ViralKumar, Vasani, and I am at Sagar Hospital, Banashankari and the Jayanagar as a consultant neurosurgeon. We routinely treat the epilepsy medically and surgically as a team, neuroscience team, and we had a good number of patients who basically come with the epilepsy and into the society. So let me start the discussion, Dr. Saravanan. Normally, there are two terms which is being used regularly by the people. One is seizures and another one is epilepsy. So what is the seizure and what is the epilepsy and what is the difference?
Yeah, this is a very good question, Dr. Viral. Yeah, seizure is medically defined as sudden, abnormal, excessive discharge from a localized brain area that can manifest differently in different people, and this manifestation depends upon the area of the brain that is affected. Like it can cause a convulsive seizure wherein the patient will have the typical conversions where they can have a jerking of the limbs, or they can just be loss of consciousness, staring episodes, abnormal continuous repetitive movements which is called automatism, or it can just be some behavioral abnormalities which are episodic. So these things is called as a seizure. When one episode keeps recurring, the similar kind of episode or a different kind of episode keeps recurring, then it is called an epilepsy. So we have to differentiate if it is just a one-off an event or it is a recurring event. So when it's a recurring event, it is called an epilepsy. Again, epilepsy is a generic term. Like if I want to give you an analogy, epilepsy is like telling fever. Just by telling fever, we don't understand anything. Fever can be caused because of lot of reasons, like you can have because of typhoid, malaria, tuberculosis, any viral infection. Similarly, epilepsy is a generic term. So it is a group of disorders which manifest as seizures, wherein we try to find what is the cause for epilepsy and try to treat those causes. Same way, I would request you to enlighten what is the importance to know about epilepsy for a general population, or else what could be the why we are conducting this show as such. Yeah. That is what is the thing.
This is very essential, when we see in the community, there are a lot of people who comes with the epilepsy, but rather epilepsy, there will be a social stigma associated with it. And there are a lot of myths, which actually, in community we see so many people come with the different facts in their mind, which are actually taboos. And those myths has to be busted. The people should know that epilepsy is a treatable disease or it is controllable disease. If the taboos are associated, then they may have a lot of consequences. We have seen people, who put something gag when they have a convulsion or they have an epilepsy. They'll put something in the mouth, they will come with the injury, lot of injury, teeth avulsions. We have seen the fractures. So if the taboos are there, if the people do not know what is the actual symptoms and how to identify the seizures, they will not know how to control it. So that's why we selected today that it is very essential for every one of us to know what is exactly epilepsy and why it should be treated. Now, since people come here with epilepsy and every day we will be seeing, I would like to ask you a question. How a common man should identify that a person is having epilepsy?
Yes. So like I told earlier, like depending upon the part of the brain that is causing that abnormal discharge, the manifestation of seizures might vary. But the commonest manifestation, like everyone knows, it is patient becoming unconscious, falling and jerking of all four limbs. So this is the classical presentation of a generalized epilepsy, what we call it. And there are other types of epilepsy which we call it either a focal epilepsy or a complex partial seizures, or different classifications are there. This focal epilepsy could be just in one area, like just a jerking of one hand kind of a thing continuously, or one limb, something like that. It can progress on to involve the whole body and the patient might lose consciousness. So that is one type of epilepsy. Another one is in pediatric age group, you might just see that the child is just staring for some time, then again comes back to normal, then few episodes, a few seconds of staring, then come back to normal. Child may not be aware of it. So these are episodes of staring spells during which patient is completely amnesic or will not know what is happening around. So these are also some type of epilepsy. There are other things wherein we call as complex partial seizure, wherein the patient might have some automatism or abnormal repetitive movements, like the lip smacking kind of a thing, chewing, swallowing, or just some massaging movements, or like buttoning, picking with the button, picking the cloth, these kind of things which are just repeating, which are non-purposive completely. Patient, if you try to speak to them, they may vocalize, they may not vocalize, but once they gain consciousness, they may not be aware of what was happening. So this is also another type of fits. So symptomatology varies depending upon the location of the brain that is being affected.
So there are a lot of symptoms associated with epilepsy, and since the symptomatology is so much, that there is a possibility that there will be some amount of mimics, isn't it?
That is true, definitely. So that is the job of the neurologist or the doctor to find out whether whatever the symptomatology is actually fitting into a seizure or epilepsy, or it is something else.
Yes.
So that is why the main, for us to diagnose, the main important thing is the history. The bystander who is standing by the patient gives us the maximum information to make a diagnosis. Mimics are things wherein patient can come to a doctor wherein symptomatically it might look like a seizure, like just a loss of consciousness. So loss of consciousness can happen because of seizures. It can happen because of drop in BP. It can happen because of lot of reasons or metabolic causes. So we try to evaluate and find out whether it is because of proper seizure or a non-seizure mimic. So that is the important thing to distinguish for us to decide about the management. Because a seizure or a recurrent epilepsy may require a slightly prolonged medication than a non-seizure or mimic, which may be completely different line of management. So seizures have to be differentiated from the mimics. The common causes for the mimics are either low sugar, BP dropping, any cardiac issues. These are the common ones.
Yeah, very good.
Yes.
So the most important part here, what I feel, is that once you see some symptoms, you should actually come and ask the experts. Unless they ask the expert, they will not be able to find out what exactly is going on, isn't it?
Yes.
So it's always better to consult a neurologist who is expert in the field, and then they should ask the questions and present them what exactly has happened.
That is true. That is true. Before that, the bystander should know what is the first aid when a patient is having a seizure. So I would request Dr. Viral to tell me what is the first aid patient or an attender should be taking care to say that the patient is safe before he reaches to the doctor or the hospital.
Yeah. It's a really good question, because every one of us should know that once the patient is having seizure, what is my role? Because everybody tries to do different things. I can share you my experience, small experience, where people have tried putting mouth gags. Somebody has given the shoes, foul smelling
smell of
socks,
smooth or foul smells.
Yeah, exactly. So I have seen so many people doing such a different weird ideas. I don't know from where they get it.
Properly, people see a lot of Bollywood movies. I think they're in there. As soon as someone gets a seizure, they will try to get a metal and give it to the hand.
Exactly.
So those things are like
these are dangerous actually. So when a person is having seizure, the bystander, first thing, because seizure can happen in any condition. If a person is sitting, standing or sleeping, in any condition, a seizure can happen. So the first thing is to make the patient should not fall. How do we do it? If the person is standing, just make them lie down. Clear the surroundings, let the person lie down first. Second thing is, since the either patient will be seizing or not seizing. It depends on the different symptoms. But then make sure that his clothes are loosely, loosened easily, so that tie is there, coat is there. Remove the tie and loosen the clothes, open the button so that he can have better breathing. He should not have hypoxic injuries because of the tight clothes, because they will be seizing at that time and they will not be aware of surroundings. Clear the surroundings, people are there. Normally when we see roadside, it happens that the entire crowd comes and they'll be so eager to see what is happening inside.
Yeah.
That is the worst condition where the patient will have more hypoxic brain damage. So make sure that the air circulates to surrounding, and then his space is cleared. Shout for help. Ask somebody to give the ambulance help or to call for a help, so that they can transport the patient to the nearest hospital as soon as possible, where the neurological facility is available, and then emergencies can treat that part. Another thing which they should be doing is, till the movements continues, like if a person is seizing, having convulsive movements, they should not do anything. Don't give any mouth gag, don't give any metal hard things in their hands, don't even try to control the convulsive movement. Just let the convulsion stop by itself and you arrange for the help. Suppose if this is happening at home, another person who is witnessing the seizure, they should actually take a videograph, so that it helps us in guiding what was exactly happening.
What is the type of seizure? That is where we do differentiate between whether it is a mimic or an actual seizure. We might doctors might get additional information by looking at the video. So
Exactly.
Different person should be, one person who is helping the patient should not be doing it. Other someone else is there, they can take a video that gives us a better idea of what is happening.
Exactly. And then the moment the patient stops seizing, it means then movement stop, patient becomes okay, patient will be unconscious for some time. So at that time, put the patient in left lateral decubitus position, wherein the patient's left side should be touching the earth and the right side should be up, and let him lie down in a tilted position, so that there is no tongue fall and patient doesn't have any hypoxic brain injury.
That's true. That's true. Very good, very good. So like he said, by looking at the videos and this thing, we should, like movies, we should not be trying to suppress the abnormal jerking movements or pressing, because it can cause fractures, and there should be no sharp objects or metal objects are needed in the patient's hand, or nothing should be given into the mouth for drinking, or to gag the mouth also nothing should be done. So all these things should be avoided, because that will cause more damage than help to the patient.
Exactly.
So this is a take home from the first aid point of view.
Exactly, and everybody should remember these points, because this is the one, when this happens, we will be seeing in the surrounding. When it happens, we will be actually doing the same thing. So try to do the things and arrange for an ambulance and shift the patient to the nearest emergency room for the medication, especially. Along with this, there are so many myths prevalent in our community. So Dr. Saravanan, can you just tell us about few myths about epilepsy?
Epilepsy is one condition where there is a lot of myths than there are facts. Even though facts are there, only the myths are getting circulated more. So like I told you, like in the movies and all, what they show us, like what you're not supposed to do, that's what is being shown. So similarly, don't learn from places where you're not supposed to learn. So first thing is, it is thought that it is some bad spirit or bad evil. It has nothing to do with spirituality or any evil or bad spirit. It is a medical condition, like any other medical condition. Like anyone can have a diabetes, hypertension, fever, any other medical condition. This is also a medical condition. It requires adequate diagnosis and treatment, that by a proper doctor, neurologist. Another myth is that people who are having these seizures are having psychiatric issues. It may not be completely true. Some people might have it, but that's two different entities, so both have to be managed separately. This is not a psychiatric illness, this is a medical illness. Third, there are a lot of other stigmas associated with the epilepsy. That is why these stigmas are because of these myths. So myths have to be busted. The patients should know this is a treatable condition, and they should come out more aware of it, because of which it can the patient can be more acceptable in the society. Now any patient, female of any young female, if she has a seizure, the parents try to suppress the fact and they try to get them married.
Right.
They tell that like because of marriage, seizures will get cured, get her married fast, and all those things. So it should not be done like that. So a proper medical diagnosis has to be made. We have to diagnose whether it's just one of an event like a seizure or it's a recurring event kind of a thing. So when it's a recurring event, we put them on medications to control it, and once it is well controlled, we tell them like they can have their own normal life. This doesn't affect their normal lifestyle. Only thing is we tell them when the patient is having recurrent seizures, we tell them certain precautions. Like a patient with epilepsy should not be driving vehicle. At least in India, we don't have a law which permits them to drive vehicles. We tell them not to go to heights alone so that they don't have a risk of fall. Not to go for swimming. And these are common things which we tell them. That is just for general care kind of a thing. So once epilepsy is under control, things can be appropriately managed.
Yes. So basically, epilepsy should be treated.
Yes.
It has to be treated by a neurologist.
That's true.
Exactly. And there are medicine, as you said, that it can be treated with medicine, isn't it?
That's true.
So everybody should, think about this, that before we do anything about epilepsy, let's consult a neurologist and then find out what exactly to be done for that, isn't it? Yeah.
Yes.
Since we are doing this one, everybody will have one more questions, that when I go to a doctor, they will give me a 10,000 investigations. Why should I do all investigations and all? Is that really required for a diagnosis of epilepsy? This question I usually see that people keeps asking me in clinics and all.
Sure.
And I always feel that, there are a lot of mimics, as you rightly pointed out in the initial part of our discussion, that the patient can have so many causes behind the epilepsies. And there will be epilepsy mimics also, where drop in heart blood pressure, or they have cardiac arrhythmias, which can actually, cause a syncope and a patient falls down. Sometimes some psychogenic episodes. There are so many associated things are there. So everything has to be ruled out before we label the person that the patient is having epilepsy, isn't it? One of the things which I suggest them, that when your doctor asks you an investigation, it is to find out whether this is rightly treatable.
That's true.
Can it be treated? Is it treatable? Is it curable? Or is it controllable? Isn't
true.
it?
That's true. So the list of most commonly the investigation is done in the first few visits, so that we are able to distinguish between whether it is a treatable cause, whether it is a controllable cause, or any surgery or advanced methods of control is required, or first of all to identify what is causing it first of all. Like I gave you an analogy in the beginning that fever is like telling nothing to us. For a doctor point of view, we have to know what is the cause for fever. So we do a lot of blood tests to find out what is the cause for fever and treat accordingly. Same way epilepsy, just by blood test we may not be able to identify. So we ask for certain tests. The commonest one being EEG and its various types of EEG, either at 24-hour EEG, video EEG, or depending upon the type of the clinical diagnosis, we ask for an EEG to classify the type of seizure and to get additional information about the seizure. And second one is to see if any structural damage, anything is there in the brain or any other problem is there, we ask for an imaging. These are the basic investigations we ask. Plus, to rule out the mimics, we might ask some basic blood tests also.
Yeah.
So these are the three basic levels of investigation which we commonly do in the beginning. During the follow-up, depending upon the medications, we might suggest some investigations, but not frequently.
Yeah. There is somebody who had actually asked a question in a comment box. I'll just read out first. My niece is suffering with spinomuscular atrophy type 1. She is 6 months old. Can you help us for her treatment?
Yeah, there is this. We are not discussing about spinomuscular atrophy today. I would request you to call the hospital helpline desk so we can connect you to our pediatric neurologist and they will be able to
guide you.
Yeah,
very true.
Thank you.
So kindly do that. See, another questions which I had in my mind is every day you will be seeing a case scenario.
Yes.
Can you just explain one of the case which you saw today and how did you try and treat that patient?
Yes. See, like I told already, the young woman. So today there was a 10th standard girl who had come to me with, today morning she got up, she had one episode of fit, she just fell down on the floor and she seizure before she was about to attend her class. So the parents are panicking, they got her. So when we go through the history, I found out that so she used to have some features which was suggestive of seizures, where a minor seizure we call it. So what is called as myoclonic jerk, where they can just have a jerk like that. So those kind of histories were there. And her last night's sleep was disturbed. So these indicate some kind of a genetic epilepsy or juvenile myoclonic epilepsy. So based on the history, we make a probable diagnosis. So from me, maybe a first episode, they might have not noticed the previous episodes. So even if a first episode, we might sometimes get clue towards a genetic epilepsies or a treatable epilepsies kind of a thing. So this young woman, again, patients were apprehensive because she was a woman, girl. She will get married in some time, has to bear child. So parents will have a lot of anxiety. So that brings about their anxiety kind of a thing. So we just have to sit with the parents and the patient and explain them this is like any other medical illness. Like in diabetes, you take either a tablet for diabetes or insulin for diabetes and go ahead with your life. Here also you just need another tablet, go ahead with your life.
Yeah.
So your lifestyle management has to be slightly better in compared to other normal people, but most of the time it is a normal routine. Only thing we tell is be regular. If the patient is having epilepsy, we tell them be regular on medication, have adequate sleep, avoid stress, avoid alcohol as much as possible, avoid bright light, flickering light. Sometimes in some patients it can trigger off, so try to reduce the usage of computer screen in this thing as much as possible. So I had to sit with them, counsel them. We did a basic investigations. EEG was abnormal, which was suggestive of a JME. So we have started her on anti-epileptics. We'll have to follow her up. So we have to explain them this is not a one-time medicine like for fever. It is not like fever you treat for 7 to 10 days and then stop it. It might require a long-term medication. Sometimes initially we treat for minimum of 3 to 5 years. If there is no fits, then we might give a consider, but certain genetic epilepsies we might not stop it. Some condition where we don't find any specific cause and there is complete control, we might give a single trial of stopping the medicines.
Yeah.
That is one thing. So that can be decided on the follow-up. That all those questions cannot be answered on the first day. So we require them to follow up regularly, be regular on medication. Based on the compliance, based on the seizure control, we take a further decision of what is to be done.
Yes. So one more question is there.
Yeah.
Can epilepsy suddenly start at the midlife? We don't have any family history.
Yes, epilepsy can start at any age. So commonly we see it in pediatric age group, even in the teenage and early age group. But even some patients can develop. So at that time is what is the thing our importance comes in, whether it is a true seizure or an epilepsy or a seizure mimic. Yes. So we try to differentiate, and based on the cause, first line of management is always medication. So we try to give the medicines. If we find any treatable cause like sugar being low or calcium being low or some infection, so we try to treat those and adjust accordingly. If it's a seizure mimic, then we might not put them on fixed medicine and treat the other cause and try to adjust the medicines. Yes. Dr. Viral, can you share any of your patients' experience about seizures or anything which you keep, or from your surgical point of view, what they come and ask you from epilepsy, for epilepsy?
Yeah. So normally patient comes to us always are the referral patient because they are already being diagnosed either by neurologist or being referred by a physician or something who actually come for the either evaluation or directly by treatment. So I would share two cases scenario where I remember that there was a 4-year-old child who comes with the frequent falls. So they say he is running, suddenly he will fall down. He will not have any strength in the legs. That's what the parents said. And if you see his face, he would have multiple injury over the face or the arms, shoulders and all. And then he will, whenever we ask him that why you had a fall, then he will say, I don't know, I was running and then I don't remember anything what has happened. So then we actually, evaluated by a neurologist, and then they found that there are multiple discharges which is coming from one hemisphere and it is getting spread to the other. And then he is having generalized seizure and then dropout attacks and all. So then they started putting on medications one after the other, and then he was on the full dose of 4 medications, but still seizure was not under control. So they gave us a palliative plan. Can we do something to at least prevent the spread of a seizures to the other hemisphere so that their quality of life can be improved? So we assessed the child, we evaluated, and then we did surgery called as corpus callosotomy, and then the child become better.
That's good.
Yeah. So another thing which another case where 36-year female patient would a software engineer actually, but then she had a kind of seizure, but then she neglected it. She said nothing has happened, and she never visited a doctor initially. Then maybe after 3 months, again she had one more episode of seizure where the colleagues have seen, and then they took them to a physician, and physician saw, and he said you have to meet a neurologist. Then the colleague said no, I think it's not a good idea to go to neurologist because the brain doctors they will give so many investigations and all, some stigmas. So they delayed by a year. The frequency of seizures started increasing as the age progressed, and after a year I think she had a fall and she had a head injury, and then she was brought to the hospital. They did a CT scan for the head injury part, but then we saw that there is a lesion inside the brain, and then when we did surgery for the patient, she had a grade 3 brain tumor. So if that lady would have come a year earlier, then the spread of the disease would have been little lesser compared to what she had at that time. So what in my experience I feel that any patient who has epilepsy and diagnosed epilepsy, they should never hesitate to go to a specialist so that they can get treated properly, they can diagnose properly, and they get proper information. Otherwise they get lot of carried away by a lot of taboos and myths and all. So yeah, one more question which people usually ask, that since the epilepsy is and recurrent seizures, what should we do to prevent the seizures?
Yes. See, epilepsy has to be properly diagnosed, and they have to be started on appropriate medication. There are lots of medications available. So the neurologist will first evaluate and first make a proper diagnosis and put you on an appropriate medication at an appropriate dose. So the dosage varies from person to person. It doesn't mean that the same dose fits for every person, kind of a thing. A fat person might require a higher dose, a thin person might require a lower dose. An adult might require a higher dose, a kid might require a lower dose. Most of them, it is based on the body weight. So that is the reason we tell them patient has to be first diagnosed appropriately, properly. They have to be started on appropriate medication, because different type of fits respond to different type of fits medication. So the neurologist knows which medicines to start and at what dose. So they will start and they will adjust the dosage for your body weight. The patient's first thing is they have to be regular with medication. If they are asked to take once a day, they have to take it once a day. If they are asked to take twice a day, they have to take it twice a day. If they are asked to take thrice a day, they have to take it thrice a day. They should not skip medicine. The commonest cause of recurrence of fits is, one is when they are very non-compliant with the medication. Okay, so the first thing is right drug at the right dosage has to be compliant. Okay. Second thing, patient, as I told, lot of things can trigger off seizures, like consuming alcohol, lack of sleep, too much of bright light, flickering light, computer screens. Try to avoid that. Too much of stress. So they have to practice meditation along with medication. That will help them in the long run. So medicine are the mainstay of treatment of epilepsy. We can go on adding on. If the patient is not getting control with one medicine, the doctor might add on a second or a third. There's no limit to it. It depends upon the patient's tolerability or the side effect profile, and based on that we might add on. And once the patient is comfortable with the medicines, we try to control a dose so that the seizure does not recur. Even with maximum anti-epileptic dose, if the patient is still having seizures, we re-evaluate the patient at this stage for any surgical remedies.
Yeah.
So at that time we do a lot of additional information, additional tests like a video EEG or a long-term EEG, a repeat functional MRI with an MRI, routine MRI with a functional MRI, or a uptake scan. All those things is to find if any localizable lesion is there that can be cured surgically. Yes. So that is, after all these things are done, we refer the patient to a neurosurgeon to treat any surgically correctable this thing. Surgically, as I told, the first line of medicine is medicines. Those who are not responding, not tolerating, or not remediable by medicines, we evaluate for surgical, and those who are fit for surgery, only those are referred to surgeries.
Yeah, exactly. So we are actually coming to an end of the session. I have two questions to ask quickly. One is, one person has asked, is epilepsy come from hereditary?
Yes. epilepsy, lot of epilepsy has a genetic background. It is still work in progress. Lot of epilepsies are not genetic. So let the doctor decide. Do not feel free to ask the doctor what is the cause. Exactly. Most of the idiopathic generalized epilepsy have some genetic underlying cause kind of a thing. Another thing I would like to say, when you're telling genetic, it doesn't mean a patient may be having the gene, he might not manifest. So that has to be important. So only that is why we don't go on doing genetic tests for everyone. So only people who are resistant, we might do this thing, because from a research point of view and even from a treatment point of view, that helps us. So genetics is just a part of the illness. There are a lot of other causes which can cause epilepsy, like head injury can cause a brain scar and that can cause an epilepsy. Like a brain infection can cause a scar in the brain, that can cause a stroke can cause. So there are a lot of other causes which can cause recurrent seizures and epilepsy. So we treat accordingly based on that.
And the last question I would ask is, what is your advice for a pregnant woman or a woman who is having epilepsy wants to get pregnant?
Very good. Yeah, this is very important. As I had from the beginning, I have been telling women, it is a special topic in the epilepsy. It has to be managed by a neurologist. Do not, first thing is, meet the doctor, take the medicines regularly. Before manage, don't try to hide the fact that girl is having epilepsy or the boy is having epilepsy. The other person should kindly explain to them that it's a treatable condition. If they are not explaining, kindly get the bride or the groom to the doctor. The doctor will speak to them, try to convince them. Tell them that the patient is in a condition, having a medical condition. It is treatable, it is controllable. Only thing is, they may have to be on a medications for a longer durations. That is one thing. Be regular on the medicine. Sometimes, like I told, during the marriage time, because of stress and all, patient may just miss medicine. They might have a seizure on the marriage, this thing itself, hall itself. That's why we tell them, kindly tell the patient, person that you have the epilepsy, so that they are aware of what has to be done. What is the first aid to be done, what has to be done, and be regular on medication. Second one, women with medication, pregnancy, we avoid certain drugs that the doctor knows, so you don't have to bother too much. They will take a call on that, which medicines to add, which medicines to order. Third, pregnancy. All women with epilepsy should have a planned pregnancy, because the seizures have to be controlled first. They have to be put on certain supplements and then they plan for pregnancy. It should not be an unplanned pregnancy, because during the pregnancy, there are a lot of medication levels will fluctuate. So that is why we want to keep a stable medication level, control your fits, and then ask you to go in for a pregnancy. Any women with epilepsy can get pregnant in the natural way. There is no difference as such. So nothing to worry about those things. They have to be, during their pregnancy, they have to regularly follow up with the neurologist also, so that the certain medicines will adjust the dosage based on, because they will be gaining weight, we'll have to adjust the medications, we'll adjust the medicines, and seizures can be controlled. Third, they will have to also follow up regularly with the gynecologist so that any adverse effects because of medicines can be monitored early, can be addressed. Though adverse effects are less than 3 to 5%, we would request you, they can do certain early anomaly scans or like triple tests to identify these problems and suggest appropriately. That should not hinder patients from stopping pregnancy, not to get apprehensive about pregnancy.
Exactly.
And not to get pregnant or stop the medicines. So they have to be taking appropriate medication and they can get pregnant.
Exactly. And if they don't take medicine, then they may have premature termination of
That's
pregnancy.
true.
All
Because
these things can happen.
a seizure and epilepsy during a pregnancy is much more dangerous than taking a medicine.
Exactly.
So I would suggest take a medicine than having a seizure during your pregnancy.
Yeah.
And last, as women age, even in elderly women, they can have seizures, they can have falls, they can have fractures. So they will also have to be taken care of to prevent seizures, identify the cause, be on the appropriate medications. That helps them in the long run.
Exactly. So the take home message is medication, meditation, consultation, and regular on your discipline of your life. Food, sleep, everything on time. So discipline is also a very important part of the controlling the epilepsies. So thank you very much, Dr. Saravanan, and thank you very much, Sagar Hospital, for arranging such a fantastic session for the people to understand about epilepsy and be aware about it, and then trying to do what is best for themselves. and trying to not to do which is worse for themselves.
Yes.
So I think this will be more informative for all the people.
Not to
in
spread
a long run.
myths.
Yeah, exactly.
That's true. That is more important.
Yeah. So thank you very much.
Thank you, Dr. Viral. Thank you.